Hello and welcome to the WFPICCS World PICU Awareness Week 2025 podcast series. I am Dr. Manu Sundaram, an attending physician at Sildra Medicine in Doha, Qatar. This is at the time of the year to recognize the incredible work done in pediatric intensive care units around the world. This year, we are focusing on a crucial theme: technology and innovation in PICU. The goal is to highlight how PICUs everywhere, from cutting-edge hospitals in major cities to resource-limited settings in remote regions, are driving change. Innovation in pediatric critical care isn't just about the latest high-tech equipment. It's about creative problem-solving, adaptability, and making a difference in children's lives. With me, I have three brilliant speakers from the Middle East region. I'll let the speakers introduce themselves. So I hand over to Dr. Omar Daifi to introduce himself.
Hello, everybody. My name is Omar Difai. I'm an intensivist from Royal Hospital. I have an interest in sepsis, mainly sepsis screening tools and medical simulation. I'm already working in Muscat Royal Hospital.
Thank you, Dr. Omar. Next, I have Dr. Abdul Rahman Daitan from Kuwait, and I'll let him introduce himself.
Thank you, Dr. Manu. I'm Dr. Abdurrahman Daitan. I'm a senior specialist in pediatric critical care in Kuwait Oil Company. I'm interested in developing the local PICU registry as nationwide for Kuwait.
Thank you, Dr. Daitan. Next, I have Dr. Khalud Said from Oman.
Hello, everyone. My name is Khulud. I am pediatric intensivist working at Royal Hospital. I have a special interest in acute non-invasive ventilation, and I'm going to talk about the Iceman approach in initiation non-invasive ventilation.
Thank you all for your kind introduction. I would love to hear in brief an overview about the landscape of pediatric intensive care in your countries.
Okay, so our PICU includes medical, surgical, and cardiac ICU. Our center is a referral center in the country, and our annual admission to the medical ICU and high dependency is around 1,600 patients. And we receive a total of 2,000 patients combined from medical and cardiac admissions. The center receives patients with complex background who requires diagnostic assessment and treatment from all over the country. And our PICU does all types of respiratory support, from high-flow nasal cannula to high-frequency oscillatory ventilation, CRRT, plasmapheresis, nitric oxide, and ECMO for cardiac cases.
Thank you, Dr. Khalud.
We have also, Dr. Manu, we have an ER was actually seeing around the year around more than 5,000 cases in the ER. And also we have an cardiac ICU where actually we are operating around 550 cases per year.
Thank you, Dr. Omar. And now let's hear from Dr. Abdul Rahman from Kuwait.
Thank you, Dr. Manu. So, as for Kuwait, we have a total of 7 medical pediatric intensive care units that's admitting around 2,000 to 2,500 annually with different kind of care. Some have medical, some take medical and surgical. Initially, we lacked the data that's gonna help in developing the guideline protocols that need to flourish from the data that each units have. And with the building the registry, we were able to reach that point.
Before we get into the individual projects, I would like to briefly hear from our three speakers as to what drives innovation. Over to Dr. Khalud first.
This is a very interesting question. Thank you, Manu. In my opinion, what drives innovation is your needs assessment. And the needs assessment comes from the reviews of the unit's key performance indicators, morbidity and mortality reviews, and clinical discussions around the medical cases. And I think when an issue is identified in the pediatric ICU, the team tries to come up with an innovative solutions. So I think, having a problem drives people to try to solve it. So, for example, in our unit, home ventilation team was created following morbidities related to accidental dislodgement of tracheostomy. The second factor which probably drives innovation is implementing a significant result from a previously published work. An example of that is implementing sepsis bundles from Surviving Sepsis Campaign Guidelines 2016 and 2020. And I think what assists with the implementation process is having a trained group within the intensive care on patients' quality and safety. And for us, we were privileged to have a trained team of physicians and nursing on system improvement, and that enabled us into changing ideas to quality initiatives.
So I think what drives innovation for me is actually creativity. So we want actually to create something new. Okay, like in our case, we actually elected to use something new that's actually it is a screening tool. And the other actually that drives innovation is actually curiosity. Like if you see, like the thinking that if you to use something new, if you create something new, it's actually it can alert the data or alert the situation or alert your data. This is something actually that could drive innovation. That's for me actually the major two things actually they can drive innovation in our setting.
So for me, what's drive innovation is I don't want to be the person with opinion. So as Dr. Deming was mentioning, without data, you're just another person with an opinion. So if you're gonna say this is important or this is have a top priority to be taken care of regarding policies, suggestions, something outbreaks, you need to have data to support your opinion. So it's not become just an opinion; it's become something that people listen to you and to give it that, as I remember from Dr. Kotter's framework, that usually urgency is the first step. So urgency, it's gonna give you the sense you need to innovate, you need to um, invent something that will help you to reach the point that your opinion is not just an opinion, it's a data driven decision. So to reach that, you need to be innovative.
Thank you very much, Dr. Abdul Rahman. Now let's get to the meat of the discussion. Let's start with sepsis, a time-critical diagnosis where every minute counts. Dr. Omar, your team in Oman has developed and implemented a sepsis screening tool that integrates with your clinical workflows. Tell us what led to its creation.
This creation actually came up from a group. We name it Sepsis Improvement Team. And this team consists of pediatrician and nurses. Actually, we came with this project after having actually little bit struggling with the sepsis rate and mortality related to sepsis, where actually our data was exceeding the worldwide. The worldwide benchmark. This actually project started earlier in 2018, but actually abandoned because of COVID. We initiated actually the program again and really to lower the benchmark of sepsis incidence and also mortality related to sepsis. And we came up with a program that actually used to screen all cases of sepsis in order actually to recognize them earlier and also to start managing them earlier. And that's how this program is started.
So can you tell us a bit about this tool that you created?
Sure. Actually, this tool is it is actually and we use our internal servers. We use actually a web page using the internal server. This page actually consists of three main criteria or three main actually columns on it. The first one is actually the patient complaints. If it is fever, if it is actually new infective symptoms, or this is mainly of it. The other actually column is actually the background of the patient. If the patient having chronic illness, or this patient recently received a chemotherapy, or actually this child or this patient has a central line in place, which make it a risk for sepsis. The third column actually consists of the red flags, mainly the signs that patient exhibit, like fever, tachycardia, or bradycardia, and mottling of the skin, and also included the blood pressure on it. This is the main three criteria actually we include in the screening. That it that like that the nurses when entering actually this web page, she will find certain columns where actually she need to put the MRI number of the patient. Also, she need to put her number, her staff number, and the place that she did actually screening for, screening in with and the time and the date actually it will come automatically, or she can change the time actually if she enter it like later on or within 1 hour of the screening. And the tool actually after the nurse putting the she tick actually what is the criteria or what is the box actually indicating for the patient. There are three main screens coming after that. So if the patient, for example, they screen him and he is not septic, so the after she entered all the criteria needed, it will come like a screen that this patient is not septic. So she need to do the actually the screening again if the patient exhibit a new symptoms or the next day if the patient admitted. But if the nurse actually she put the criteria, uh, um, she put actually the issues and the patient turned to be, for example, high risk. A pop-up screen will come out. It will indicate that the patient actually is high risk of sepsis. So, and will come actually already with an order. So this screening should be done every shift, so every 8 hours. We don't have to wait for the new symptoms. No, the screening will be done every 8 hours, or if there is a new symptoms arising, like example fever, or mottled skin, or other red flags. In other hand, if the patient actually is septic, and the nurse she entered all the data, and the patient is turned to be septic, there is a pop-up screen will come, and where actually it will indicate the patient is actually having sepsis, and actually a link it will appear. It will after clicking that link, it will go for a new page where actually the management data will be there. So in the management data, the nurse will actually it will be easily read. The MRI number of the patient will be printed on that paper, and also the staff number to be also there, and where is actually the patient is detected in the ward, in the ER, or in Heidi. And then the page actually is self-inflammatory, so it will it is actually it will tell the nurse what to do, to call the consultant or the registrar, and then after the registrar coming, he will actually confirm that it's sepsis or not, and then he will start management, like collecting the labs, starting antibiotics, starting boluses, or starting antibiotic support, and also to indicate when they call actually the ICU. So this is actually in short how they actually the screening done, and what actually the outcome of the screening.
Thank you, Dr. Omar. So this is something in addition to your electronic medical records. Is that right?
Yes, it is actually in addition to it. We didn't integrate it yet with the Shifa system because we are using a system called the Shifa system. It is not integrated there because it need a sophisticated software to put it in. But actually, we are hoping in the coming system that actually to be incorporated in that system. It is now parallel. It's working parallel to that system.
Thank you very much. How has this changed the timeline for diagnosis and intervention in sepsis?
Actually, our data is really positive from that perspective. Like actually, we decrease the intervention actually from previously we released up to 5 hours to treat sepsis. Now, no, we are actually strict with the golden hour, and actually we are recognizing sepsis earlier. So, like in ER, our data shows that patient from seeing in the triage to start treatment, we reach up to 30 minutes now. Like from triage to starting management, or like cannulas, fluids, and antibiotics. Our data show that actually in the world, from the time of detection of sepsis to implementing of management, up to 45 minutes with each. This is actually how this actually changed our intervention to sepsis, like detecting sepsis to treatment. Like our data now showed actually a reduction in the PICU admission rate to less than 15% in the last 6 months, from July 2024 to December 2024. Also, our data showed in the last 6 months that our mortality rate due to sepsis is actually less than 10% also. So we are actually doing great from that perspective, and this is how actually the screening changing the timeline to diagnosis and also to intervention and also to outcome. And it actually showed that we are actually doing well from that perspective, with actually promising areas for improvement from that of the screening tool we have.
Thank you very much. What has been the staff response and how do you manage false positive alerts?
Actually, from the staff response, we started this actually in the screening process in October 2023. And our aim was actually to make it or to build a culture, not to force the nurses to do it. Like our perspective or our objective at that time, that if we actually improve the culture regarding sepsis and regarding the importance of sepsis and how it actually changing the outcome, the nurses, they will do it without our force, or they will do it like from themselves. And this is actually like a change, change our actually view for sepsis a lot. So we spend a lot of time actually teaching the nurses, teaching how it is the important of detecting sepsis and how important of treating sepsis on time, how it changed the admission rate to ICU, and also the overall stay in the hospital and the cost of it. And we're actually having a good response from the nursing staff, and actually they like it. And from that time, actually, our screening compliance is always exceeding 80%. We did a benchmark of 80% for screening. This was our screening compliance is always more than 80. In fact, in some of the wards, actually, we are having it 95 and above for the last 6 months. And this is indicating actually that this is becoming a culture, and the nurses, they are really aware about the sepsis, and they are doing it like in a daily manner, and it helps us a lot in diagnosis and intervening for sepsis. And even the feedback from the nurses regarding the screening, that the overall time they need is around 15 to 20 seconds to fill the form. It's becoming easier for them because it's parallel, and they can use it in the same computer, and can use it parallel to the Shifa system that we are using at the Royal Hospital. So they find it like convenient that the same data they can pull out from the Shifa system, they put it on the screening tool, and also they are actually finding it also even they find that this screening improve their communication towards the doctor, like how they communicate with them, what they tell them, how this form change their communication skills also, and how they inform the doctor of this patient is septic or not. So we're actually having a good response from the nursing staff mainly.
Does your tool complement the Phoenix score?
Actually, in the Phoenix score, actually it is different than the Phoenix score, because in the Phoenix score, actually they are waiting for other labs like lactate and other labs actually to determine what is the sepsis, if the which degree of sepsis, and after that to determine the management. Our sepsis is quite different because first it can be done by nurses. It can be done from the triage without waiting for the actually for the labs. And the other things also differ from the Phoenix score. The other actually they are our sepsis screening is already have been like validated from other from other places like UK and Spain. We are using similar to this screening with actually a good result. We are actually looking forward to use the Phoenix score, or looking for ways to implement Phoenix score in our screening tools. But this is now the main difference, that we are actually finding it from the Phoenix score. Our screening tools differ from the Phoenix tool from these two main points that I mentioned.
And my last question to you would be, what advice would you give to other ICUs in the region looking to implement a similar tool?
So my advice, actually, if they want to actually decrease the admission rate to the ICUs, this tool actually it might help them, or they can actually adopt similar tools where actually they can with it they can actually reduce the admission rate to ICU, and by this actually it might help them actually reducing the mortality rate due to sepsis also. So actually it's an area actually they can actually investigate, and and also an area they can also improve on it also. And we are happy also in Oman actually to if the other PICUs in the region, they want actually to hear our sepsis screening program. We are happy to help them, and we are happy also to learn from them if they have any innovation like this also regarding sepsis screening.
Thank you, Dr. Moore. Dr. Abdurrahman Daital, data is often called the new oxygen in healthcare. You have been leading the development of a PICU registry in Kuwait, a major step forward for the region. Can you walk us through how this registry came to life?
Thank you, Dr. Mano. So the registry initially was started at mid 2022 when I started doing my fellowship. So initially, I worked in the pediatric critical care units for a couple of years before I go to to my fellowship, and I was involved in multiple administrative projects. And the question was always coming to my mind when some administrative project, like for example, if you're gonna take care regarding the CLAPSI or CAUTI, which project should you give it more priority? So to decide this, it has to be built on data. So when I came to search, honestly, I couldn't find any data that's regulated and will form that support the decision regarding which project should give him priority to. So at at this point, I started to look for registries worldwide, and unfortunately, there are some registry that's really lengthy and it takes really long time to fill, and it has so much variables that it cannot fit in the unit. So at this point, I decided, so if I'm gonna build my decision regarding which priority should I give, it should be based on data. And from that point of view, the decision regarding we need to have a registry, we need to have a data that drive the decision, and to build the registry. That was the point that break down the decision regarding we need to start to have a registry nationwide.
Thank you very much. And can you just tell a bit more about how did you create this registry?
So, in creating the registry, initially, it was built by Google Spreadsheet, and it has a plugin which was a company called AppSheet created a plugin for the Google Spreadsheet that it's reflected all the variables in as an app. It's a non-coding platform, so you're gonna transform your Google Spreadsheet or Excel sheet into an app on the phone. And having the app on the phone is easily to utilize. You're gonna spread it to champions and leaders of the data in each unit. Each unit will have the champion. Initially, he was entering the patient discharge variables when the patient discharge, or for example, there's a mortality. Like he entered the patient data, and we collect this data. With time, they became as a champion and supervisor, and anyone who's doing the discharge summary, they are supervising him, making sure that with the discharge summary you are entering the data. They made sure that the quality of the data is going with the variables definitions that we built, that each variable it has its definition, and he knows exactly that what does that mean. For example, if I'm gonna say intubated patient, do trach consider intubated, yes or no? That variable, it has its own definition through the registry, and he can easily grasp like yes or no regarding that variable.
Thank you. It's interesting that you've gone for app-based or a phone-based registry, which is different from the other registries. What type of data are collected and how frequently are these data collected and how time-consuming is it?
I made sure that each entry is not gonna take more than 5 minutes, and I keep having we are doing uh, check in out every site. So every 4 months we extract the data, and I do the analysis and extract all the data, make sure that the quality of data is with accepted range. And if there is any major error, like for example, if suddenly someone entered the discharge date, like the length of stay became 2 years too long, we go back to that champion and discuss with him, is it truly like this patient took 2 years? Then suddenly we find maybe there was some error and he tried to correct, or it's truly the patient was chronic in the ICU, so it took 2 years for him to get out. So it's regarding how fast they are entering. I made sure that it does not exceed 5 minutes, because otherwise people will not be happy with entering the data, and it's gonna take time consuming, especially during the season, winter season, that people want something really fast, accessible, which is on their phone. It does not take more than 5 minutes to. Usually, it's 2 to 3. Maybe once or twice that patients stay high frequency, stay for a long duration, that require to enter many variables, but normally it's usually take 2 to 3 minutes. The variables we're choosing that it's really have a value for the head of the unit and the unit itself. For example, if we need to know like how much NIV we consume. So because during the season we need the mask, we need the equipment, the connections. So if you don't know how many patients you have on an IV during the season, you cannot request for that items. So it's give you a background. It's like how many patient you expect to have during the season. So you prepare your item ahead. If you have lacking in the nurses staff, during the last season, for example, if your unit covered 400 patients, so you need to calculate your manpower, so doctors and nurses. So there's a lot of information that the data will be driven, and it's built that it does not give you dirty data, so it's unnecessary and uninformative data is I avoid it as much as I can. So there's no variables that is not gonna affect the unit as a whole.
And when is the data entry done for the patient? Is it per patient during discharge or on a daily basis that's kept updated?
So the data entry usually on discharge, because there are variables that you will never know unless the patient goes through the discharge. So, for example, the outcome of the patient. You need to know if the patient discharged to the ward, discharged to the HDU, or, for example, unfortunately, mortality can happen. So to know that, you need to enter it on discharge. That was agreement by the whole team that we need to do it on discharge. So even we collect the culture output, the nasopharyngeal aspirates, and the result of the variables is already there. So you're gonna enter it once the patient discharged.
Thank you. And what's the preliminary insight from the registry and how has it influenced critical care in Kuwait?
So we have the task force, which is a task force built for the pediatric critical care for the nationwide, and it's involved all the unit of the pediatric ICUs in Kuwait. We do develop our own guidelines and protocol internally. So to decide which priority should we give to which protocol is gonna be according to how many patients do we have. For example, if I'm gonna say let's decide regarding develop a protocol for ARDS. We need to know how many patients for ARDS do we have annually, or for example, critical asthma. So that's helped a lot in deciding which protocols should be taken into consideration and given priority compared to the other. Add to that, like there are multiple outbreaks that happened during the past 2 years. For example, the pertussis outbreak mid last season, which was also detected by the registry, and it gave us the guide that we need to look what's going on, what's happening, why we have a high rate of pertussis. Then when we look to the registry, we find there's a high surge and peaking of the number of pertussis patients admitted to the PICU, and that led to the research opportunity in the GCC. And you know that now we're taking lead in the research regarding the pertussis. So it can recognize outbreaks. It can help decide regarding we need to give priority to these guidelines, to this policy over others.
Do you see any opportunities for a regional collaboration across the borders using this model?
Definitely. I've already talked to a couple of pediatric intensive care units in the region, and they were more than welcome to the idea that they to join us, and eventually we can do the benchmark, not just internally, even externally.
Thank you, Dr. Abdul Rahman. Now let's move on to non-invasive ventilation, which continues to evolve in pediatrics. The Iceman algorithm is a structured approach to safely initiating non-invasive ventilation, and this has been adopted extensively by Dr. Khalud Said from Oman. I'll let her introduce the Iceman framework and explain how it works and how it assists in clinicians in making NIV decisions in real time.
Thank you, Manu. This is a very good question. The Iceman is a structured approach that provides a comprehensive tool to the assessment and the management of pediatric patients needing non-invasive ventilation. This mnemonic stands for certain steps in the process of NIV initiation. So the I refers to indications. So during this step, we review the indications for NIV initiation. So the indication could include either type 1 respiratory failure or type 2 respiratory failure. The C stands for contraindications, and during this step, we review the contraindications for non-invasive ventilation initiation. This is an important step to make sure that NIV is not provided to diseases with high failure rates, such as pediatric ARDS, hemodynamic instability, or encephalopathy. It's important that we exclude patients with contraindications to non-invasive ventilation, and this is because delayed invasive ventilation is associated with increased mortality in the PICU. Now, coming to the letter E, it stands for equipments. And during this step, we will decide about which equipments do we need. So that would include the type of ventilator, tubing, and what interfaces should be used. The M stands for the mode. And during this step, we will either choose whether we are going to go for continuous positive airway pressure, CPAP, or bilevel support, depending on the indications for NIV in each case. The A stands for analysis of failure. And during this step, we troubleshoot the possible causes for non-response to non-invasive ventilation. Examples are hypoxia or hypercapnia. The N stands for next steps, and this is the last step. And during the last step, we decide whether we are dealing with a responder to non-invasive ventilation, where we continue monitoring, or whether we have a failure, where we might need to change the settings of non-invasive or the mode, or go to invasive ventilation. Now, coming to the second part of your question, how does Iceman approach assist clinicians in making decisions in real time? I think this is very important, and it's very important to understand that Iceman approach provides a structured approach for the assessment and the management of patients needing NIV, and therefore it becomes protocolized for everyone initiating NIV. The second thing, or the second important point here, is that if you have a structured approach like Iceman approach, it will reduce the risks of inappropriate patient selections for acute NIV. So by excluding patients with contraindications for non-invasive ventilation, we make sure that our initiation is done on the right population of patients. The third thing is that it provides a framework for analysis of failures to non-invasive ventilation, and hence it assists in troubleshooting non-responders to non-invasive ventilation. Therefore, it provides a comprehensive approach to the initiation and monitoring of non-invasive ventilation.
That's very exciting. Has this approach reduced or has it reduced unnecessary intubations or delays in escalation of care for patients with respiratory failure?
This is a great question, and I think the Iceman approach has helped us to standardize our training to non-invasive ventilation. Now, looking at the outcome of implementing non-invasive ventilation in our unit, we have seen a reduction in the invasive ventilation. So the invasive ventilation was required in 12.7% of our patient cohorts who were started on non-invasive ventilation for different diseases, including bronchiolitis, pneumonia, asthma, and acute chest syndrome. So that was done, on a retrospective analysis of 299 patients, where we evaluated the outcome of using non-invasive ventilation in patients presenting with acute respiratory distress. The other advantages is that we found that initiating non-invasive ventilation in our unit has reduced the escalation to PICU, and that in 78% of patients who were treated with non-invasive ventilation in our high dependency unit or our step-down unit, 78% of them did not require to go to the PICU. Among patients with severe bronchiolitis who were treated with non-invasive ventilation in high dependency unit, we also found that 87.5% of those patients were successfully treated in high dependency unit, and they did not require escalation of care to PICU. That played a major role in reducing escalation to PICU, and therefore allowed the PICU to look after patients who fails NIV or those who have higher severity of disease, and that was very helpful for us from resource management.
This significantly frees up PICU bed space, isn't it? So are there any efforts to integrate this into electronic records of clinical pathways in your country?
So the Iceman approach right now is part of our educational packages for our nursing team and pediatric trainees. Currently, we are having regular training on non-invasive, and that includes the use of Iceman approach. And we try to target the training around the bronchiolitis season so that we can catch up with any new staff. In addition to that, NIV training and Iceman approach training is part of the curriculum for the pediatric residents. So in terms of including that in the training, it is already there. We haven't changed it yet into electronic checklist.
Let's just ask Dr. Abdurrahman Deetan, our registry expert, as to how this can be integrated into registries, and has he integrated this data into his registry in Kuwait?
Thank you, Dr. Mano. Currently, we are tracking the non-invasive use, and we're planning to add the days on non-invasive. So we track the duration that's taking the patient to be on non-invasive. As mentioned by Dr. Khulud, the Iceman framework is amazing to help the patient to be on non-invasive and to educate the people. We might add it in a way that is easily gonna be part of a guideline protocol for the patient to initiate on non-invasive, so the people can easily refer to references electronically on the phone and see, for example, as a PDF, what they have to go through on initiating an IV.
And my final question for Dr. Khaluda and for Dr. Abdurrahman would be, should we expand this to other centers or adapt it for post-acute care settings?
So for us, right now, by targeting the training for pediatric trainees, we are actually trying to expand it to the rest of the regions in the country, because the pediatric trainees come from different regions in the country. They get their training, in the capital city, and after that they go back to their regions. So by catching up with the trainees, we hope that the NIV training is spread to the rest of the country. So this is one of the steps where we are trying to catch up with as many people as we can. In addition to that, obviously there are regular NIV workshops that we try to include in local conferences to try as well to educate as much as we can.
Thank you very much. Each of these projects reflect leadership, innovation, and a deep understanding of the local context. But innovation comes with challenges. What barriers have you faced, whether it's technical, cultural, or resource-based? And I'll leave this question open to three of our speakers.
I think one of the commonest barriers was the staff buy-in and engagement with a new idea, as it takes time to breed a new culture or a new change. So, that was probably the most important thing that I have encountered. The second point was financial resources. So if we take, for example, implementing NIV requires ventilator accessories such as tubing and interfaces, which needs to be renewed. And as we expanded the surface of non-invasive ventilation, the cost of non-invasive ventilation went up. And it was important at that point in time and at this stage to show that the advantages of implementing NIV, like comparing the ICU stay for responders of non-invasive, which is shorter, versus those who requires invasive ventilation, and reflecting on the fact that use of non-invasive and high dependency unit reduced escalation to ICU. So to me, the most important two barriers were engaging the staff into the new ideas and allocating resources for your quality project.
Yeah, Kaman, from my side, Kaman, also I have two major barriers actually. Barrier number one is integrating the sepsis screening tool into actually the hospital system instead of making it parallel with it. Like instead of using the internal server, is actually to use it within the system itself. So if we have actually integrated into the system and we allow the system actually by itself, because now we are in the era actually of artificial intelligence. And I'm sure also they are actually, because I work in other institute actually, where actually by putting the patient's background and vital signs, actually there is a pop-up screens coming by spontaneously that the patient is septic, and we need to pay attention for that. And this is my major actually barrier actually to integrate sepsis screening in the hospital system. The other barrier is actually because we are a teaching hospital, we are actually having turnover a lot of the residents, and keep them all aware about the sepsis and sepsis screening is quite challenging. And now actually we started integrating actually the serial lectures about sepsis and sepsis screening within the teaching institute. But the other challenge will be actually integrating the same teaching serial lectures actually within the hospital for the coming residents and interns also. So those my two barriers actually that I'm facing for this innovation, for my innovation.
As for the registry, one of the major barrier is the actually we lost one of the champions. He moved out of the hospital to another country, so uh, which required which required us to recruit a new champion to cover that hospital. But we know the turnover of doctors is there. Luckily, the learning curve for the registry is very minimum. It's a short period, so it didn't require us a lengthy learning curve, and the new champion took over. But other than that, I think it's easy, maybe for the data analytic at the end of the year to do the data analysis for the whole registry. It's a bit challenging. It takes a lot of time to do analysis for 2000 to 2500 patient to extract a really informative report. But with time, things are, as mentioned before, that with the evolving AI, with the involvement using ChatGPT, sometimes I utilize it to help with the analysis, and eventually things are getting shorter rather than it takes 2 weeks to do that data analysis. Now, currently, it's around 1 week, sometimes even like 5 days to get the final report.
Thank you. Let's look to the future. In one sentence, what is that next big thing that you hope to see in the Middle Eastern ICUs?
I will go first. My the actually what I'm seeing in the near future, that now with the era of AI actually, I'm hoping to see more of AI integration into the ICU, and I'm hoping to use also AI in screening for sepsis. This is the major things I'm dreaming that it might be implemented in ICU soon.
Regarding the registry, my dream is for the future is to have capable machine learning with algorithm that be able to have the influx of data from the patient monitor. I still do believe that we underrate the monitor data. The variables in there is so solid that if we build a machine learning algorithm that it can intake that flux of data and extract how predictive it is, I think that's gonna be the future. It's gonna tell you like this patient is most likely he's gonna deteriorate within the coming 24 hours, or this patient is have a high risk of sepsis. You need to be cautious, and it's gonna help regarding um everything. It's not gonna take off the doctor. He still need the doctor, the nurse, but it's gonna be supportive to patient care.
This brings us to the end of this powerful conversation. A big thank you to Dr. Khalud Said, Dr. Omar Al-Daifi, and Dr. Abdurrahman Al-Daitan for sharing their experience, passion, and wisdom. Your work is a beacon for what's possible when technology meets purpose in pediatric care. Thank you for your patient listening.
Thank you very much for this opportunity.
Thank you.
Thank you. It's a pleasure to be here today.